and welcome to another episode of the Healing Lyme Summit. I'm your host, Dr. Mariah Hinchy, and today we're going to talk about mast cell activation syndrome in relation to Lyme disease and other vector-borne illnesses. So, Lyme is an inflammatory, immune dysregulating infection that infects and affects every cell in the body. So, it's not surprising that it's going to cause dysfunction in mast cells in a lot of patients, too. Mast cell activation syndrome causes a ton of different symptoms, and they can affect every single system of the body, just like Lyme and vector-borne diseases. And there's quite a bit of overlap in the symptoms. So, here to talk us through, teach us more about what it is, what the relationship is, and what to do about it is Tanya Dempsey, MD. So, Dr. Dempsey is a board certified internist, and she is an expert in chronic disease, autoimmune disease, as well as mast cell activation syndrome. So, welcome, Dr. Dempsey. Thank you so much for joining us. Let our audience know how you came to specialize in this.
Well, first off, thank you for having me. One of my passions is educating. And so I love talking about what I do every day, and that is take care of patients with complex chronic diseases. How I landed on mast cell activation syndrome is a little bit of an interesting story, but the reality is that I've always been very sort of open and always with this mindset of root cause medicine. Even when I was doing general internal medicine, I always wanted to understand why something was happening to a particular patient. And because I was interested in root cause stuff, I also was always talking to patients and listening, and more importantly, listening to them. And so when you listen, you're more likely to find things and start to understand how the pieces fit together. And so so actually looking back, the point is that I think I was seeing a lot of patients with mast cell activation syndrome, and now I can see that in retrospect. And I knew that there was something immune dysregulating, but I didn't really understand the full aspect of it until I was already on my own in my own personalized medicine practice, where I had that one patient that was not getting better and was getting worse and had multi-system symptoms that didn't really fit into any other box that we could find, that there was nothing else that really explained her symptoms. And I remember one day doing a little literature search. I was on PubMed. I think I was even on Google because I was really determined to figure this out. And I came across mast cell activation syndrome, and this was probably somewhere around 2014, maybe close to 2015. And that was really just kind of the beginning of the information we had on MCAS. But once I sort of looked at it and thought about it and talked to the patient about it, it all made sense. And then I connected with Dr. Larry Afrin, who is really I consider him the world's expert in mast cell activation syndrome. And then eventually I brought him on board to my practice. And so we're practicing together and researching and studying and really trying to understand this disease better so that we can help more patients. So
That's amazing. That's great. What better than to bring in the world expert, right, to your practice and work with him? I love that. Thank you for everything that you do. So, let's start by talking about what is mast cell activation syndrome for the listeners, who are patients.
Sure. So, I think the best way to think about it, the quick version of it, the elevator speech on it really is, it's a chronic, complex, multi-system disorder. And so what that really means is that this is a condition that affects multiple parts of the body. So symptoms in one part of the body alone probably is not mast cell activation syndrome. And we're looking at mast cells in particular, right? So let's talk a little bit to understand this syndrome. I think it's good to really even understand the cells involved in the syndrome. And these cells, these mast cells, are white blood cells. Now we have white blood cells. They lots of different ones. They fight infection. They help protect us from the environment. They do a lot of different things. Mast cells are white blood cells that actually live in tissue in the body. So we have white blood cells that are flowing through the blood vessels. They're in your veins, they're in your arteries, they're circulating. Mast cells actually stay in tissue, in the organs, and that's where they are our first line of defense against everything, the external environment, the internal environment. And they are part of what we call the primitive immune system or the innate immune system. So they are positioned to be the first line of defense. And one of the ways they protect us is that when they see something they don't like, they literally explode. Okay, we call it degranulate. They release granules of chemicals, we call those mediators, in order to fight off what they see as foreign. Now, mast cells are involved in allergy. So I'll give you a little bit of a primer on allergy. So if somebody has just allergies, okay, they may or may not have mast cell activation syndrome, but they're, let's say, allergic to pollen. The mast cells in the respiratory tract see the pollen. They see that they're allergic to the pollen. They tell the mast cell that there's a signal to the mast cells that the pollen is bad and it needs to be dealt with. And the way that the mast cells deal with it is they'll explode, they'll release histamine. That's one of the drivers of allergic symptoms. Histamine is very inflammatory. So in response to the histamine, you get everything swells up. You might get itchy. You might have trouble breathing. There are lots of different things that happen, right? That's what mast cells are responsible for. Again, towards this allergy. Now, in an allergy situation, typically you kind of sort of deal with the allergy, you avoid the allergy, you get allergy shots, you take allergy medicine. And as long as you're not exposed to what you're allergic to, generally speaking, those mast cells will sort of just hang out and wait for the next thing. In mast cell activation syndrome, which by the way, could include allergy, but doesn't have to include allergy. You can have mast cell activation syndrome without allergy. You can have allergy without mast cell activation syndrome. And you can have allergy and mast cell activation syndrome. But in people with this mast cell activation syndrome, what happens is these mast cells, which I said are really all over the body. I talked about allergy in the respiratory tract and in the skin, but again, mast cells are everywhere. When they read a signal that's abnormal to it, they will explode. They will release various chemicals. Histamine is just one chemical that they can release. They don't have to release histamine. Many mast cells don't make histamine. They make other chemicals. There are over 1,000 different chemicals that mast cells can produce. And in this release of these chemicals then are they're sort of designed to maybe help kill whatever they're trying to kill, but really it backfires. And all those chemicals are in our tissue and then causes inflammation. So in mast cell activation syndrome, these are mast cells that are abnormal. They're reacting abnormally to the environment. There may be triggers that are real, but they're probably not that bad. Somebody without mast cell activation syndrome may or may not even realize that there's something bad in the environment, but people with MCAS are reading things at a very, very low level. So it's more intense, it's more aberrant, more abnormal. And that leads to a variety of symptoms, and it can affect every single body part, organ, system in the body. To meet the criteria for mast cell activation syndrome, you typically need more than 2 systems involved. So again, if you only have allergy and you only have respiratory symptoms with the allergy, but you have no other problem in any other part of the body, that's not mast cell activation syndrome. If you have allergic symptoms, let's say, and you have symptoms that involve, let's say, you have bowel issues, gastrointestinal issues, if you have heart issues or palpitations, maybe you have neurologic symptoms, neuropathies. If you have things that are involved in other parts of the body, then you can say this is a multi-system condition. and that, may meet the criteria for mast cell activation syndrome. But I want to make a point about allergy and histamine, and that is that, again, you can have allergy and mast cell activation syndrome, and you can have mast cell activation syndrome that looks like allergy, but is not truly allergy. So some of my patients wind up in an allergist office and they know they're, let's say, reacting to pollen or they're reacting to a food. They get tested and everything is negative. It's not that they don't have allergy, but they have an exaggerated response from the mast cell through a different pathway. So it looks like allergy, but it won't meet the criteria for a true allergy. But there are also mast cell patients who have no allergic symptoms whatsoever. And this is probably the most misunderstood piece. And I really want to drive this point home because a lot of patients are discounted when they say they don't have allergic symptoms. I think that since this disease and the syndrome is being popularized, I think there are more practitioners who are starting to understand it to some extent, or at least they've heard it, but they make an assumption that people have to have allergic symptoms. They have to have trouble breathing, or they have to have respiratory symptoms of various kinds, or hives. But there's a subset of patients with MCAS who do not have anything that even resembles allergy, and they still have mast cell activation syndrome. So if I can send this message home to patients, to maybe there are practitioners listening, if the patient has multiple symptoms in other parts of the body, but they don't have allergy, they can still have mast cell activation syndrome. So
Okay.
that's
So,
that's important.
and we need to have at least two systems being
Correct.
affected.
Correct.
So, two questions. The first one is, so what are the common, like, obviously we're talking about infections inducing this. So in addition to infections, what are some other things that would cause someone to develop mast cell activation syndrome?
What we understand is that there's the vast majority of people with mast cell activation syndrome are probably born with a predisposition. They're born with, we'll call it, somewhat dysfunctional mast cells. Maybe there's a familial history. Maybe there usually is other family members who have some flavor of mast cell activation syndrome. So they're born with this predisposition, and we call this idiopathic, really, mast cell activation syndrome. So it starts at a very young age, and then they have the predisposition. It doesn't mean they're going to go on and develop full-blown MCAS, but they might have mast cells that are a little bit more finicky. And so over time, with various insults, various um, exposures, those dysfunctional mast cells can become more dysfunctional, and then over time lead to the full-blown development of mast cell activation syndrome. So there are patients with Lyme disease, with infection, who had mast cell activation syndrome before the infection, but maybe they had very mild symptoms. And then they get the infection, and it could be Lyme, it could be Bartonella, Babesia, it could be a parasite, it could be a virus, could be the flu, could be COVID, could be Epstein-Barr, could be even a toxin in the environment, a pesticide, a mold toxin. There are lots and lots and lots of things in the environment that can trigger the mast cell. And with every trigger of something sort of dangerous, foreign, toxic, these mast cells sort of basically reach a new sort of baseline where they're more reactive and more reactive and more reactive over time, right? So I would say that that is definitely the majority of patients, at least that I see in my practice. When you take a really good history, sometimes patients think that a particular incident is what caused their mast cell activation syndrome. We see this a lot actually in the long COVID world.
Mhm.
Very healthy people who then got COVID and then have lingering symptoms. But really, the majority of them, I would say, and I would never say all of them, but the majority of them had some flavor probably of MCAS. When we take a good history, we see that there were some things already sort of at a very low level, but these are very healthy people, so it's not really affecting them. But then that major trigger brought it out. There is a subset of patients, though, who have what's called secondary mast cell activation syndrome, and um, they have, let's just say, totally normal mast cells. There's no genetic predisposition, there's no family history, there's no nothing. They're born normal history, but then at some point in their life, there's a trauma, an infection, a toxin exposure that then literally mutates these mast cells to become dysfunctional. But in that case of secondary, the taking away the trigger may actually reset the mast cells back to completely normal. Someone who was normal, lived in a moldy home, got mast cell activation syndrome, got mold exposure, and mycotoxin illness, and then they're treated. They leave the house, they get treated. And for them, if they didn't have anything wrong before, it's possible that their mast cells will reset and their health will just go back to where they were before. I would say that's actually, unfortunately, rather rare because most of those patients with secondary, those mast cells get mutated in a way that they may not return to normal. And then that does suggest that maybe there was something going on earlier that we just didn't even realize. So it's
Right.
complicated, but that's sort of the way I think about this.
Okay. So is it a clinical diagnosis, or are there tests that you can do to diagnose it, or is it a combination of the two?
Yeah, I think the best way to think about it is that it really should be a combination. You need the clinical symptoms, you need the clinical sort of manifestations, you need to be able to understand, right? The patient has to meet those criteria of um, multi-system, uh, disease that doesn't, let's say symptoms that are not explained by other diseases. But sure, I'm a scientist at heart, and so I really would like to have a diagnosis. I think that getting a diagnosis using testing um, gives the patient, validates the patient, gives them a credible diagnosis that they can then tell their other providers about that. Again, then they have that credibility that they're not discounted, they're not disbelieved, right? So I think it's important. The challenge is that testing is can be difficult. And so I think there's always going to be people who are not going to be able to either do the testing, or they do the testing, but the testing doesn't show anything abnormal. And so we just have to be careful. There are cases where we can't find the abnormal results, but really there's everything about their clinical picture, including response to treatment. They've tried things for mast cell activation syndrome and they seem to get better. So we make an assumption that they probably have it. The testing involves really a handful of tests that we can measure, mediators that we measure. Actually, these are the things that mast cells release. We try to grab them from the blood or in the urine. I said earlier that mast cells make over 1,000 chemicals. If we only have a couple of handfuls of things that we can measure, at most, there are going to be people who don't meet the criteria by our testing, but that's because maybe they have one of these mediators that we just don't have the testing for. So I think we have to treat the patient ultimately, and that the patient is the one that needs, to be treated, not just the tests themselves.
Yeah, absolutely. Do you want to share with the listeners what like those, handful of tests
Sure.
are? Because I know like testing for histamine is not, like that's not it. So what are the other mediators? I mean, I know histamine plays its role,
It plays a role, right?
but
Exactly.
as you've pointed out to me, histamine is not the end all be all. So what are the other things that we can look at and evaluate again with the clinical picture? Um,
Yeah. So, so a plasma histamine and a whole blood histamine might be worth doing, because when you get it, it's helpful. It's one piece of information that can be used towards making the diagnosis. And ideally, I would want two. Not only do I want two body parts affected, essentially, but I want two pieces of laboratory evidence to support the diagnosis. So histamine can certainly be positive, and that could be one point of reference. In addition, we have chromogranin A. Some of these mediators are not specific to the mast cell. They have other cells that are making them, I should say, but we can use some of these depending on the level. Chromogranin A is one. Tryptase is the one that gets the most press. And unfortunately, because tryptase is made by mast cells, there are lots of people who do not have elevated tryptase. But some of the old thinking on this is that you need an elevated tryptase to make the diagnosis. And you need to be testing when people are really symptomatic in order to see if the tryptase goes up. And I will just say that, again, I think that's a different way of approaching this. And so our way of approaching it is saying, sure, if we get an elevated tryptase, we're going to act on it. We're just going to try to figure out what that means. But if it's negative, it doesn't mean that patient doesn't have a mast cell condition. Elevated tryptase, though, can mean other things, and so that's going to require other types of testing. But it rarely is a marker for mast cell activation syndrome alone. That's what I'll say about tryptase. And then there are markers like heparin. Heparin is a really interesting chemical. It is a blood thinner. It's used in hospitals when people have blood clots. The mast cell is the only cell in the body that actually makes heparin at really, really minuscule amounts. But if we can, there are certain labs that can measure down to those minuscule amounts. And when we catch an elevated heparin in the blood, then we know that it must be mast cell activation syndrome. It's a very specific marker because, and sensitive actually, sensitive and specific marker, because there's really nothing else that could be doing that unless somebody is actually taking heparin. So that's a really great test. And then there are urine markers, mediators that we can detect both in random urine samples and in 24-hour urine samples. And we have things like N-methylhistamine, which is a metabolite of histamine. We have leukotrienes, we have prostaglandin D2, we have 2,3-diner, oh, hold on. I don't know why, but I always, not always, diner, beta. Okay, hold on, I'll get it. 2,3-diner 11 beta, prostaglandin F2 alpha.
That is a mouthful.
Yeah, a little bit, a little bit. Dr. Afrin does it so seamlessly, really, it's just so beautiful, but I usually stumble on it. But in any case, we have these various mediators that we can collect in the urine. The challenge is really that the people who are collecting it, the labs that you're going to, they have to know how to handle the specimens. At home, people have to be really careful with the specimens. They have to keep it cold, and so there's a whole routine. Like we don't do the testing in our lab per se, but we do have a lab here in the office where we process everything and then get it to the lab that's actually going to run the samples. And we have a whole technique here, how we educate our patients and how we process things so that we get hopefully more reliable results.
Right. Wow. Okay. So, Dr. Dempsey, let our listeners know how and where they can contact you if they're interested in more information or becoming a patient, and let them know if you have any upcoming events or exciting news to share.
Sure. So, I'm on social media. Instagram is Dear Tanya Dempsey, MD. Facebook, Dr. Tanya Dempsey. My website, drtanyadempsey.com. I have lots of information. I do lots of videos and podcasts. I have a new podcast. So I do put that on my social media, but if people want to listen, it's called Mast Cell Matters. And that's been exciting. We have a few more. We have a few already released, and we have a few more coming down the pike. But I think that having this podcast about mast cell activation syndrome is really great and exciting, and just want to keep getting the word out and interviewing some of the best in this field. And I think that's all I can think of for now. I'm sure there's more,
Okay,
but
great.
yeah.
I'm excited to hear your podcast. I definitely want to learn more. I know like the tip of the iceberg here with mast
Totally.
cell activation syndrome. So Dr. Dempsey, I have so many more questions for you. We haven't even really talked. Now we talked about how it's multi-system, but we haven't even really gotten into what the actual symptoms of mast cell activation are. So can you share that with us?
Sure. Well, I'll start from sort of head to toe. I think that's probably the easiest way to do it. Um, and again, there are some symptoms that can be linked to other conditions. So just because you have this symptom doesn't mean you have mast cell activation syndrome. I want to be clear, right?
Mhm.
Headaches are, let's say, a symptom of MCAS. Migraines can be actually a symptom related to MCAS. But people can have migraines and not have MCAS, right? So I just want to be clear that we'd be careful not to attribute everything to MCAS. But headaches definitely are a possible symptom. We see eye issues, blurry vision, change in vision. We see ringing in the ears, change in hearing, trouble swallowing. There's various digestive issues. Can be we've seen SIBO and slow motility issues, gastroparesis, um, colitis, respiratory issues can be like an asthma like situation, could be cough, could be just reactivity in general to things in the environment that way. The skin, there could be hives, but there could be other kinds of skin manifestations, things that look like eczema, there are psoriasis, there are lots of different things that may be linked to MCAS or may manifest like MCAS. Um, there are, I think about like going down to the pelvic region. In men, we sometimes see uh, pelvic pain. They can have testicular pain. So they can have post-orgasmic pain. Women too, they can have the same. They can have post-orgasmic pain. They can have pelvic pain. They can have endometriosis, various menstrual irregularities, various hormonal irregularities. And I'm sure I'm forgetting, but and then osteoporosis is associated with MCAS, arthritis, muscle issues, neuropathies, other neurologic issues, neuropsychiatric issues, depression, anxiety, OCD, eating disorders. Um, again, the list goes on. I'm probably forgetting something in that mix. Connective tissue issues, cranial cervical instability, tethered cord, sleep apnea. Um, the list goes on.
Okay. So how does Lyme, in your opinion, like how does that infection induce mast cell activation syndrome? Is it infecting the mast cell? Is it just a part of like the immune dysfunction? Is it the inflammation? Is it all of it? Like, do we know what the actual connection is that triggers this in some patients? Because as you're, rambling off the symptoms, it's like, yep, that's a symptom of Lyme, symptom of Lyme, symptom,
Right,
on and on and on. It's like,
right.
there's just, it's very close to being 100% overlap in the
Oh,
symptoms.
absolutely, absolutely. So the way I look at it is that for some patients, the Lyme is a trigger for their mast cells. So I said early on, right, that the mast cells are reading your environment. We know that as part of the primitive part of the immune system, the mast cells from thousands, tens of thousands of years ago, mast cells were helping us fight off parasites. They were helping us fight off funguses and bacteria and lots of things. So if that's their job to help us fight those infections, you can imagine if you get a chronic infection like Lyme, or potentially chronic infection like Lyme, that you're going to set off that part of the immune system and rev it up. The problem is that in chronic type cases, the mast cells are then constantly seeing this infection. and
Mhm.
they're constantly reacting. So I think there are a couple of different things that happen. So the Lyme kind of spurs on those mast cells. The mast cells talk to other parts of the immune system. They talk to the part of the immune system that produces antibodies. We have these other white blood cells, lymphocytes that are involved in, we have T cells and B cells. And we have these cells that make antibodies. Some Lyme patients have positive ANAs and rheumatoid factors, and they have Hashimoto's, and all of a sudden they have all these antibodies. And so what we believe is actually that the mast cell may be responsible for sending the signal to these cells, like there's danger, we got to do something. And that part of the immune system starts to get dysregulated and starts making antibodies, just trying to fight, not very effectively, unfortunately, but nonetheless trying to fight off infection. So I think that's one part of this. I don't think that Lyme is directly infecting mast cells, although I guess that's absolutely possible. We just haven't seen that yet. I think there's more research that needs to be done. And then I think the other part is that once you've had an infection like Lyme, so for some patients, the immune dysregulation piece of it is more pronounced than the infection piece of it. So even in some patients who are treated and maybe treated effectively, maybe their immune system continues to fight. And there are others where I don't really think the infection is gone. I think the immune system is dysregulated, but I also think the infection is still there, spurring this on and keeping the mast cells continuously in this state of disarray, constantly releasing these chemicals, constantly causing inflammation. And the way I think about it is I think the symptomatology, okay, and some of the stuff I'm saying, we have not published on yet, okay, so, but it needs to be published. But what I believe is that the symptoms that patients are experiencing with, let's say, Lyme or Babesia or Bartonella or whatever the vector-borne infections we're talking about, some of the symptoms are actually, I think, being driven by the mast cell, and some of them are being driven by the actual organism. I think it's a combination of both. And I think in some cases, when you treat infection and you get what we sometimes call a Herxheimer reaction, for some patients, that Herxheimer reaction is in fact mast cell activation syndrome. It is the release of toxin, let's say when you're treating those infections, but then that is flaring the mast cells even more, causing that whole set of symptoms that looks like it could be a worsening of their Lyme, but may in fact be part of the mast cell response. So
Right,
it's
and we know that so
complicated.
much of the herx is inflammation driven too, so, like, this makes sense, right, that the mast cell is actually playing a role, like, in reaction to the LPS maybe and causing part of this inflammatory piece of the Herxheimer reaction. That's very interesting. So what treatments and interventions, and please talk about pharmaceutical as well as nutraceutical or herbal, whatever you would like to comment on, do you like to use or are available to treat mast cell activation syndrome?
Well, first and foremost, the number one thing you need to do when we think about treatment is really to first make sure that you eliminate triggers.
Mhm.
So if you know that you're exposed to mold, you know that there's something in your environment, you're dealing with a very stressful event, whatever it is, you've got to deal with those things first before even thinking about medication and all that. Those are going to be important, but as long as you're constantly being exposed to the triggers, it's going to be hard to treat. And that includes the infection itself, right? And sometimes with some patients, there's a little bit of a like I think of it like a seesaw type of thing going on between I'm trying to treat the Lyme, but I know if I don't treat the mast cell piece, they're going to flare more. But if I don't treat the Lyme, their mast cell flares more. So it kind of is a little bit of a catch-22 in some ways. And so that's like the one part. And then to treat the mast cell directly, to basically calm this situation down, first line would be what we call antihistamines, H1 blockers and H2 blockers. So we said earlier, histamine may not be the whole story. But having said that, mast cells typically do have histamine receptors on their surface. Those receptors on their surface are what is they are reading the environment with. And so they have these histamine receptors, and even if histamine isn't a major issue or a major mediator, sometimes putting that H1 blocker, that histamine 1 receptor blocker, antihistamine, can maybe send that signal to the mast cell like, hey, calm down, stop reacting so much. For some people where histamine is an issue, yeah, blocking the histamine at the level of the mast cell, but also in other cells in the body can be helpful and reduce symptoms. And there are lots of over-the-counter antihistamines, and there are some prescription antihistamines. We have different histamine receptors all over our body. So we're talking about these typical sort of antihistamines are what we call H1 blockers. Claritin, Zyzol, Zyrtec, Benadryl, things like that. And then we have these other antihistamines. They're called H2 blockers because they block a different histamine receptor. The H2s tend to be more in the GI tract. They are sort of elsewhere, but a lot of them in the GI tract. And so a lot of these drugs are used actually for GI symptoms, for reflux and heartburn, but they can help block histamine. Things like Pepcid or famotidine, Tagamet, Zantac, so things like that. So finding the right one of the H1, finding the right one for the H2, that sometimes is really, really helpful. There are other medications that we use. There are mast cell stabilizers. Ketotifen is one, cromolyn is another. Low-dose naltrexone is one of my favorites. Certainly doesn't work for everyone, but can help modulate the immune system beyond the mast cell. From a supplement perspective, from a like nutraceutical perspective, there are things that digest histamine down, diamine oxidase. There are things that block histamine, vitamin C and quercetin. They also can be mast cell stabilizers. There are a number of other sort of natural products. Resveratrol is another one. There are lots of them that actually have some mast cell stabilizing properties. And then again, lots of other drugs potentially that can help, and all the way over to chemotherapy agents potentially. Um, I have no idea. This is the problem. What for each person is going to work for them, which one is going to work best. That's some of the research actually that we're trying to do, is trying to look at the mast cells to see if we can do genetic sequencing to figure out that this particular mast cell maybe is making more of histamine. So we know that we're going to use everything possible for histamine, but maybe that's the cell that's making more prostaglandin D2. So maybe we need to target things and use things like Celebrex or Mobic or NSAIDs. So once we can get to the part of the research where we can really kind of determine what the person's main issue is, I think it's going to be much easier. But right now, it's a lot of trial and error.
Right. So it sounds like there's kind of three goals. So number one is to block the two histamine receptors. Number two would be to do things to stabilize the mast cell and make it a little bit more tolerant, to the environment so it doesn't degranulate as easily. And then number three would be to kind of like gobble up the histamine and the inflammatory compounds. So maybe like proteolytic enzymes, something like that. But the big above all of that is finding what that trigger is, especially if it's an infection or a toxin or, something that we need to actually focus on either getting out of the patient or getting the patient out of that environment, right? If it's an environmental trigger.
Exactly.
So awesome. Okay. So with any of these interventions that you've mentioned, are there side effects that people should be on the lookout for?
I think there are a couple of key points that I think we need to talk about. In addition to all these big triggers that we talked about in the environment, medications and supplements are combined with excipients during the manufacturing process. You take a Claritin. There are different formulations of Claritin. Some of them have lactose in them. Some of them have mannitol. Some of them there are various ingredients in different formulations. And so for some patients, they don't realize it, but they may be actually sensitive to one of these excipients. And so they may react, let's say, to an intervention. It may not be the drug itself. It might very well be one of these fillers or excipients. We see that in the pharmaceutical side, and we see that on the nutraceutical side. Magnesium stearate, microcrystalline cellulose. There are a number of things that are quite ubiquitous in supplements, but that for some patients might be an issue, and for others, not at all. So I think paying attention, if you're someone who trials lots of medications and supplements and reacts a lot, my guess is you're not reacting to all those compounds. You're probably reacting to something that mixed with them. So I would go, I have patients who create elaborate spreadsheets to try to figure out what the overlap between the different medications are, to try to figure out, oh, wait a second, there's this one ingredient that's been in everything I've tried. Now maybe that's why I'm reacting. So now either you have to find a formulation without that, or you have to compound it. So it can be complicated, but definitely can be very much worthwhile, because if you could figure that out, you then wind up having options and maybe being able to tolerate a lot more than you thought. So that's the one thing that I would always keep in mind. In general, these drugs can either work beautifully, not work at all, or cause weird reactions. And these weird reactions may be the excipient part, but it could be the compound, the drug, or the supplement. So again, working through all that, I think is important. And having somebody, I feel bad because there are lots of patients out there who are trying to manage this on their own because they don't have providers. But I hope that the more we educate, the more providers there will be out there who can support patients. It's much easier to do this. It's much easier for me to work with my patients on this than for the patients to do this completely alone. But if you have to do it alone, there are ways to do it, and you just have to be, rather methodical about it.
Yeah. Are there things from like a lifestyle perspective that patients can do to help to mitigate some of the symptoms?
So yeah, that's a good question. And it depends. I think it's important for patients to try to find things that generally help their reactions acutely. There may be things like some patients know that dye-free Benadryl liquid is a rescue for them. And they know that if they're having a reaction, they can turn to that. So if they react to, let's say they're trialing something else, they can always turn to their rescue Benadryl if they, let's say, reacted to the Claritin that they took or something else. But some patients don't have that yet. They're still searching for the thing that's going to get them out of the flare. So there's no, unfortunately, yeah, there's no specific thing. Everyone is different.
Okay. So, what would you say are your top three most important take home points for our listeners?
So I think number one would be to always really believe yourself, always trust your own instincts. And if you feel like something is not right and you're not getting answers, to keep looking for someone who can help you with those answers. I think that MCAS is just so complex, and so many patients are really not understood or are blamed for exaggerating or lots of I hate the word gaslighting, but in a sense that is what it is. And um, I think that just to trust your instincts, you know your body best. If there's something not right, fight for it. It's hard, but you got to fight for it.
Yeah.
That's the number one thing. And try to find people who will listen, because there are more and more. I mean, that's the thing that is reassuring to me, is that every day I connect with other practitioners who didn't know about it yesterday, but today heard about it from a patient and now want to learn more. Now they're going to help more and more patients. So I'm hopeful, that they're there, they're out there to help. Um, I guess the other thing I would think about is that, if your symptoms are, a little more unusual, unique, again, don't fit into a box, um, keep working to try to figure out what may be missing. I think there are lots of mast cell patients out there who actually don't know that they have Lyme disease, vector-borne infections, mold toxicity. So I'm going to say it like both ways. There are Lyme patients who don't realize they have mast cell activation syndrome, and vice versa.
Right.
And so I really want to encourage people to keep searching for the root, because there has to be an answer. There are absolutely MCAS patients out there who don't have infection necessarily.
Mm.
I don't think there are a lot of them, though. I mean, that's a strong statement, but I don't
Yeah.
think there are a lot that don't have something else that continues to drive these symptoms. But again, in medicine, nothing is ever all or nothing, right? So I just think that keeping aware of these things, asking to be tested, making sure that we're not missing something. At least in my practice, Bartonella is probably even more common than Lyme disease, for lots of reasons. And there's absolute overlap between the mast cell symptoms and Bartonella. And more we're seeing these patients who have done everything for their MCAS and are not getting better. And really the reason is they're not responding because there's infection there that hasn't been addressed. So those are
Yeah,
things.
and I agree with you. I think that that is more often than not.
Yeah, I think so too. Like sometimes I hope I have this sort of uh sort of not philosophy, but sort of way of thinking that I wish it wasn't, I just wish that we could not have to worry about the infection piece of this. It's exhausting, it's life changing, and we're seeing so many more young people afflicted with it. But the reality is, as much as I don't want that to be the case, the reality is it is the case. And we have to search for it. And one of the things that I really that gets under my skin the most is when people say, I was tested for Lyme and I don't
Oh,
have it,
yeah.
but they weren't tested for Bartonella, and they weren't tested for Babesia, and they weren't tested for tick-borne relapsing fever. They weren't tested for all these other things. And so how do I
Right.
know they don't really have Lyme? So
And they weren't even appropriately tested for Lyme either.
yeah, well,
So,
that's a whole
yeah.
other
Yeah.
conversation. Absolutely. Yeah. Yeah.
Okay. Anything else that you would like our listeners to know?
Uh, I don't know. We covered a lot.
Yeah.
Um,
So if
that I can think
someone
of.
needs more information, what resources are out there and available for them? And again, please share your information in case somebody would like to get a hold of you.
Yeah, I do a lot of writing. So I have my blog on my website, drtanyadempsey.com. I do a lot of reels, videos, webinars, things like that. I post on my Instagram, which is drtanyadempseymd. And then, of course, Facebook, Dr. Tanya Dempsey. I have, or Dr. Tanya Dempsey, however you want to say it. So I just like to I do put out a lot of content. And I'm always thinking about these questions. People post questions on my Instagram all the time or Facebook, and I try to address those with new reels because I'm constantly, the patients, the people out there who are listening are actually teaching me. I'm not just teaching them, they're teaching me because the questions they bring up are so profound, so insightful, makes me think even more that I want to get out there and do the research and provide more information. So I'm very interactive. I like that. I need to continue to learn because I know that I know probably this much, even though I may seem like an expert, right? I know this, like a tiny amount compared to what is, I think, really that we really need to know.
Yeah, I think we all need to keep learning, keep searching, keep learning. And, our patients are our greatest teachers. I know I learned so much from my patients, so much.
Every day,
Yeah.
every day.
Well, thank you so much for joining us. Thank you for sharing your expertise. It's been amazing interviewing you. And thank you to all of our listeners at home. We will see you on our next episode. So have a great day.